So thank you very much for the invitation to participate. And I'm going to shift gears a little bit. We've been talking about different types of complications, and obviously the weight regain after Roux-en-Y bariatric surgery is probably the most common of all the complications you'll see. My only disclosure is I'm a proctor for Apollo Endosurgery and the Overstitch. And let's talk a little bit about weight regain. We've done about 1 million Roux-en-Y gastric bypass in the last decade alone. And approximately anywhere between 20 to 30% of those patients will regain weight. So if we do the math, that's about 200,000 patients that have weight regain that are calling you, hey doctor, I had this bypass 5-10 years ago, and now I've gained all this weight back. What can you do for me? Now, we can start seeing this weight regain anywhere as early as 24 months post-surgery, but mostly we'll see the evidence of weight regain about 5 years after Roux-en-Y gastric bypass. Now, this is experience from Dr. Rosenthal at the Cleveland Clinic, and we will be able to see how dramatically increased we've been seeing in revisional surgeries after 2004. And most of this revisional surgery, yes, it could be from complications, but we have to understand that part of this can also be due to weight regain. And what are these revisional surgeries that are being done? Now, we can do revision of the anastomosis to increase the restriction, revision of the gastric pouch, elongation of the bypass intestinal loop for malabsorption and weight loss. We're seeing now more band over bypass. We can see a remnant gastrectomy and some conversion to duodenal switch or biliopancreatic diversion, again for malabsorption. Now, another chart from Dr. Rosenthal and his group at the Cleveland Clinic shows us that these revisional surgeries actually have a higher complication rate of death, leaks, and remnant leaks. So we have to be very wary of who we send for revisional surgery and what other options can be out there. So now weight regained, most people will say it's all about calories. But those of us who work with bariatric patients, we know that this is very multifactorial. And it is not only what the patient consumes, but also technique in the surgery, if there's a fistula, satiety, the length of the Roux limb, if the patient has support groups, and anything from gender to time after surgery. Now, the original surgery technique, we have to be pay close attention to its anastomosis and the documentation. Obviously, no surgeon wants to leave a wide anastomosis, but if we have the original op report, we can see what the anastomosis was supposed to be. If the patient has a large pouch or has a short bypass loop, these can be indications of a multifactorial event that causes weight regain. Now, there are anatomical post-surgical changes, which I'll show you in a video. And also, patient-dependent is something that we have to give them control over. So we have to teach them about nutrition, about a soft diet, lack of exercise, and hopefully they'll follow up with their support groups and the nutritionist to get the accessories. Now, in this video, what I want to show is that even if the surgeon left a tight anastomosis, both the pouch and the anastomosis with time are going to dilate. And this can obviously lead to weight regain and obviously decrease in restriction and decrease in satiety. Now, the anastomosis in a Roux-en-Y gastric bypass was determined to be very important with weight regain by a study done at Mayo Clinic by Dr. Abudaye. So he studied 165 patients who had undergone gastric bypass. 59% of these patients had weight regain. More than 20% of the weight regained had been lost. And over 12 months post-surgery is when the endoscopy was done to evaluate the anastomosis. 91% of these patients were women and 68% were Caucasian. Now, what he discovered was that about 30% was the mean max weight regain. The diameter of the gastrojejunal anastomosis was actually very important. And at 5 years, he noticed that an increase of 10 millimeters of the anastomosis actually showed an increase of 8% of the weight regain. And we will see this here. So here we have an anastomosis that is 10 millimeters. The patient has about 23% of weight regain. When we measure the anastomosis to be 20 millimeters, we see that the weight regain was 32% and so forth. So this actually helps us to understand that the size of the anastomosis is a very important factor for the weight regain. So how does bariatric endoscopy come into play? So we need alternative therapies to treat this weight regain. As we've seen, surgical therapies actually have a higher incidence of risks. So we want to try to manage the size of the anastomosis, since we already have a study that proves that the size actually equals in weight regain. So what else can we say about bariatric endoscopy? It's relatively safe, it's minimally invasive as it's non-surgical, it's effective. We don't have great long-standing data, but we do have long-standing data on a lot of the techniques 6 months to a year. It is definitely very reproducible, and its costs are much more acceptable than a repeat surgery. Now, the objectives of all bariatric endoscopists are to reduce the size of the anastomosis if possible, reduce the size of the pouch, meanwhile trying to increase restriction and improve satiety to help the patient lose weight. And some of these changes will actually influence gastric accommodation. So let's talk a little bit about what we can do to the gastric jejunal anastomosis. So the first and most studied is actually sclerotherapy. I'm going to talk to you about a study done again at Mayo Clinic by Dr. Aboudaye, who he took a prospective cohort study from September 2008 to March 2011, injecting sodium moroate, which is a sclerosing agent used in the GI tract. He actually had 231 post-bypass patients, most of them 5 years post-surgery, and the anastomosis initially was measured to be about 19 millimeters, with 36% weight regain. Now, he did 575 sclerotherapy sessions. Usually those patients who underwent more than one session actually had better weight stabilization than those who only underwent one. And at 6 months, he was able to show that about 92% of these patients had weight stabilization, and at 12 months, 78%. Now, 18% of the weight regained was lost, usually after 2 to 3 sclerosing therapies. This is a forest plot of all the sclerosing therapy studies that there are. And we have time from anywhere between 6 to 18 months. And they're all pretty enthusiastic about the fact that they at least give weight stabilization to those patients. And here we have an anastomosis. We will usually inject sodium moroate in all 4 quadrants. This is post-injection, and this is a chronic picture. So we see that we actually decrease the size of the anastomosis, even chronically. Now, the problem we're having is that sodium moroate in the US is not easily accessible. This is actually a chart from all the sclerosing agents. This is done by the ASG back in 2007. And the one I've highlighted is because the sodium tetradicyl sulfate is actually a lot easier to get a hold of than the sodium moroate. So for those of you who actually are interested in this type of procedure, that's maybe something to evaluate. Now, the advantages of sclerotherapy are it's very accessible, it's of easy administration, it's a short procedure time, it takes about 15 minutes, it's low cost, it's very effective, especially in short interval post-procedure time. It's very safe, it's reproducible, and yes, your patients might need multiple sessions, but again, this is something that you have to evaluate versus surgery. Now let's talk a little bit about argon plasma. Now there's not a lot of literature out there. There's actually only one paper, it's a case study that was published back in 2009. But in this SAGES event, there's actually going to be a poster presented on argon plasma coagulation and a cohort of patients. So please go and try to see it in the poster session. So here what they did was they used about 2 liters of argon. They did 3 endoscopic treatments where they influenced the entire anastomosis, so circumferential. And what they did was they reduced the anastomosis from 25 millimeters down to 10 millimeters after 3 sessions. And the patient actually said that they had satiety and restriction. Now, the benefits of this are they're very easy to do, it's very cost effective, and it's very reproducible. Now, for those of you who are program directors or have fellows, I think this would be a great project to undergo in the US, and try to get your fellows to try to publish, and seeing if a patient has a small pouch with a large anastomosis, maybe using argon plasma to try to reduce it. And this is a video just showing a circumferential burning of the argon plasma, trying to reduce the size of the anastomosis. Now, we have other endoscopic instruments, such as the over-the-scope clip or the Overstitch clip. Now, there's a study that was published back in 2010 with 94 patients who had undergone Roux-en-Y between 2008 and 2009, And they had placement of 2 clips at the site of the anastomosis. And they had 80% reduction of the site of the anastomosis. So at 12 months, they actually stated that the BMI of these post-bariatric patients had gone down from 29.7 to 27.4. Now, for those of you who haven't seen the Ovesco, it has a cap and it goes over the scope. And just imagine that we have an anastomosis here. But what it does is there's a tissue retractor that will bring the tissue inside the scope, and then you'll deploy the stent. Now, the stent is made out of nitinol, and it's not meant to fall off, so it's actually FDA approved to stay in the patient. Now, with pouch and anastomosis, what other instruments can we do? And here we have about 5 different instruments to decrease both the size of the pouch and the size of the anastomosis. Now, I won't discuss all of them, but I will go through the main ones. Now, all of you have heard of POSE at some time, and this is ROSE. This is Restorative Obesity Surgery Endoluminal, and it looks a little bit alien-like, but what it definitely does is it has 4 channels, one of them for the scope, and the others for the instruments. Now, what it'll do is it'll bring tissue in, and it'll put H fasteners on both sides of the tissue, and this will create gastric plications, and we can also use this to decrease the size of the anastomosis. So basically, we can shrink not only the pouch, but also the anastomotic size, hopefully increasing the resistance and restriction and satiety in the patient. Now, as far as studies go, in 2009, there was a trial with 20 patients who had undergone Roux-en-Y gastric bypass about 5 years earlier. They had regained about 13 kilograms, and they did plication and put endoscopic anchors, which are the H fasteners, of the rows, causing decrease in the size of the anastomosis in the pouch. Now, initially, the anastomosis was 25 millimeters, and it was reduced to 16 millimeters, and the pouch measured 7 centimeters and was reduced to 2.5. They saw at 1 month 5.8 kilograms of weight loss, and at 3 months, 8.8. Another study done by Dr. Horgan, published in 2010, he placed endoscopic anchors, and he reduced both the anastomosis and the pouch. These were 112 post-Roux-en-Y gastric bypass, and he reduced the anastomosis by 50%, reduced the pouch about 44%, and he documented loss of weight regained of 18% in his patients. StomaFix is another one of the instruments that have been very well studied. In one of the studies published in 2010, 64 patients who had undergone Roux-en-Y bypass about 5 years earlier had 23 H fasteners placed for endoscopic plication, with reduction of the anastomosis from about 22 millimeters to 9 millimeters, and shortening of the pouch to about 1/3. The weight loss was about 7.3 kilograms, and 79% had no weight regain at 12 months. Now, unfortunately, where there's good news with StomaFix, there's also not so good news. So there was a prospective randomized single-blinded study that was published in JAMA this year, who actually showed that they had planned 120 patients to undergo pouch and anastomosis reduction with a randomized 2-in-1 versus sham endoscopic procedure, with a primary efficacy endpoint of reduction of the pre-bypass excess weight of 15% or more. Now, the enrollment closed prematurely because the primary results failed to achieve the efficacy endpoint in more than 50%. So at 1 year, they only had 45 patients, and the primary efficacy outcome achieved was only 22.2%. So even though we have studies that shows that it is feasible, we do have a study published this year that shows that it might not be the best. Now, we need more. This is how the StomaFix works. We have an overtube, we have a suctioning device, and then we have the H fasteners placed across, causing then gastric plications and shrinking the size both of the anastomosis and the stomach pouch. Now, the Overstitch, this is a full-thickness endoscopic suturing system. We have a study with 25 post-Roux-en-Y gastric patients who had anastomosis of 26 millimeters approximately initially, and a pouch of 5.3 centimeters, and had regained approximately 24 kilograms. Now, post-procedure, the anastomosis was deemed to be about 6 millimeters. All of them were at least less than 12 millimeters in diameter, and the weight loss at 1 month was 11.5 kilograms, and at 6 months, 10 kilograms. Now, we have another study done by Dr. Thomas, published in 2013 in the Bariatric Times, which is a transoral outlet reduction. He had 25 patients when the average GJ anastomosis was 26.4 millimeters, and post-procedure, it was measured to be 6 millimeters. At 6 months, the patient had lost 69.5% of the weight regained post-surgery, and the average weight loss at 6 months was 11.7 kilograms. Now, I have two cartoons to explain how we actually perform these tours. Here we have the anastomosis, and what we're doing is suturing it closed. Now here we'll have interrupted sutures, and we'll cinch it closed, decreasing the size of the anastomosis. Now, after we reduce the size of the anastomosis to the size that we want it, we can then go ahead and place these same sutures across the pouch to decrease the dimension of the pouch, hopefully increasing satiety and restriction in the patient, achieving weight loss and maintaining this weight loss. Now, I have a live video from Dr. Galvao where this is the anastomosis after APC, putting suturing closed the anastomosis just to achieve a diameter of less than 1 centimeter of the anastomosis. And originally it was closer to 3. So here we're seeing how the anastomosis is going to be cinched closed, and we're seeing the apposition of tissue. And at the end, all we'll have of the anastomosis is this. So I'd be happy to take any questions, and thank you for your attention.
There is this question that having all these many devices, what will make a difference to decide to use one against the other one? Will be only cost, easiness of use? What will be the factor?
I think the factors are definitely how comfortable the physicians feel with every instrument that they use, but the goals are always the same, decreasing the anastomosis and decreasing the size. Now, some of these instruments are more costly than others, and we are definitely waiting for longer standing evidence of what happens at a year, at 2 years, at 3 years. Now, the benefits of all of these instruments are that they're all reproducible. So if we do an outlet reduction using any of these endoscopic treatments, and at 2-3 years, the patient has weight regain, we redo an endoscopy, and they've either blown the stitches or blown the H fasteners, well, we can always repeat it. So even though they might be costly for an endoscopy procedure, they're still more cost efficient than surgery.
There is this question. In case of Rose and Stoma fix, there is more than a comment than a question. The stitches by time will go through the wall. I think that will happen with any of the sutures. No?
Probably. I mean, what we're trying to achieve are full thickness scopes, full thickness suture bites. So the more full thickness we go will cause then more fibrosis, and hopefully it'll be a longer lasting change in both the anastomosis and the pouch. But ultimately, we don't have anything that's perfect. Depending on what you have, if you have a very small pouch, obviously it'll be very difficult to try to manipulate a rose, a stoma fix, or even an overstitch if the pouch is just 1 centimeter or 2, versus if all you have is a large anastomosis, maybe you'd want to try with either injecting a sclerosing agent or just APC. If you have both a large pouch and a large anastomosis, then you might want to go with something a little more aggressive with suturing or tissue.
For the audience, can you tell me about your reimbursement model for these types of procedures?
So that'll depend on how good your hospital is at getting paid. Now, a lot of these reimbursement models that I know are actually are billing as surgical codes. So their reimbursements are not that bad. Now, there's a lot of fighting with the insurance companies, but if you have a very good biller and somebody who's persistent in calling the insurance companies, most hospitals are getting paid. Now, I can't give you specific statistics as to how good they are, but I do know that some hospitals are getting surgical code reimbursements for this.
Any other questions? Thank you very much.
Thank
Nicole.
you.